As Kate mentioned, I'm Concern's regional director regional director for the Horn of Africa based in Nairobi. And I'll be speaking to you today about a major nutrition program that is being implemented in Sub-Saharan Africa by Concern. The program is called Enhanced Responses to Nutrition Emergency. And in the next 10 minutes or so, I'll be taking you through the major components of this program and discussing how such an ambitious program to strengthen health systems to deal with malnutrition in fragile and conflict-affected contexts require a longer time frame for implementation, more than the typical one-year emergency programs, projects, but also requires multi-annual funding. So I will share my screen.
We can see that, Amina.
Okay.
Just into presentation mode and you're ready to go.
Yeah, you can, it's okay. So a little bit of background on the ANI program. It is a program that's being funded under the pilot programmatic partnership by DG ECHO. It's a 3-year multi-country program that focuses on reducing malnutrition in children under 5. The budget for this program is approximately 35 million euros over 3 years, covers 5 countries that DRC, South Sudan, Sudan, Niger, and Ethiopia.
Sorry, Amina, could you just put it into slideshow mode? I'll be able to see it a bit bigger if possible. If it's stuck there, don't worry, just go ahead.
Let me try again.
I'll jump in and share it for you, Amina. Apologies.
Please.
I'm not sure what happened there.
Please.
Just a minute.
So it should be the second slide. That's where I was at. Thank you. So it is implemented in DRC, Ethiopia, Niger, and Sudan and South Sudan. And the target is to reach 700,000 people over the 3-year period and support over 300 facilities as part of the program. Through ANI, Concern aims to increase the scale, efficiency, and effectiveness of our nutrition emergency response by working through the local service providers and communities to implement proven and innovative solutions in fragile, conflict-affected, and disaster-prone countries. It is a program that's based on the Nexus approach, as it combines life-saving primary health and nutrition treatment with cash transfers, CMOM surge, early warning system, and resilience building. Next slide, please. The principal objective of this program is to contribute to reducing malnutrition, morbidity, and mortality among children under 5, who are often the most at risk due to mortality. At risk of mortality due to significant food crisis in all the countries of operation for the program. The specific objective, as I had mentioned, is to increase the scale, efficiency, and effectiveness of nutrition emergency response, but also look at preparedness and response to food and nutrition security in the target countries. The program has 3 pillars. One pillar focuses on life-saving interventions, by ensuring that quality health and nutrition services are being provided in the facilities, but also at community level using the CMAM approach. The second pillar focuses on preparedness and local capacity to respond. Again, using the CMAM surge approach. So this is looking at the capacity of the health facility to respond to increase in cases. And also looking at mechanisms that are instituted at local level or at community level to monitor changes in context that result in that surge. And based on those changes, then respond in time to ensure that the health facility or the system is not overwhelmed. The third pillar is the preventive pillar, which looks at understanding and addressing the underlying elements that make people vulnerable to undernutrition. There's a component on behavior change. There's a component of looking at infant and maternal and young child feeding practices. There's a component of WASH and other aspects of services that contribute to malnutrition. Over the course of the program, as I mentioned earlier, Concern will target 300 plus facilities in the 5 countries of operation and work with these facilities to support, but also enable them to better anticipate, prepare for, and deliver services for treatment of acute malnutrition during periods of high demands, or what we call surge. Next slide, please. Under ARNI, the resilience building for health systems and communities has 4 main components or areas of focus. One is the health system strengthening. The other area is around CMAM health surge approach. The third element is the community-based early warning systems to monitor nutrition shocks, while the fourth one is looking at community resilience building through behavior change. So I'll be speaking to each of these components as part of this presentation. Next slide, please. As I mentioned earlier, health and nutrition services under this program are being implemented through the Ministry of Health where feasible, and that is a long-term partnership between Concern and Ministry of Health in all these countries of operation. The long-term partnership, I mean, as mentioned by Kate earlier, that the context within which this program operates is one of, very weak health systems. And therefore, a big part of the program is around capacity building. Capacity building is not a short-term process, it's a long-term process, and therefore requires long-term engagement and long-term partnership with the entities concerned. It was therefore necessary for us to assess the capacities of these health facilities that we'll be supporting. And the assessment was done using the WHO model of health system building blocks. And the objective of this assessment was, of course, to identify and prioritize health facilities that are most in need of support to deliver effective health services, identify specific areas of weaknesses in health service delivery, but also develop tailored support plans for these facilities. And then, of course, as part of the program, measure changes in the health facility capacity over time. The health facility assessment tool and process allowed us to do an in-depth deep dive analysis into the capacity of these health facilities across the ARNI countries. We therefore have taken a baseline of what capacities the health systems have, and now we'll be building these the capacity of these health facilities and monitor them over the coming two years. What the assessment showed, next slide please, is extremely high level of needs in these areas. I mean, in these countries of operation. And the needs range from poor infrastructure and sanitation to lack of adequate management of medicines and equipment, insufficient readiness and response to COVID-19, as well as lack of skills or knowledge for health workers who are managing these facilities to provide CMOM services, antenatal care, child health services, and so on. The health facility assessment does not only point out the weaknesses, but provides a set of detailed, practical priority actions to address the main gaps seen. Concern, therefore, is working with this priority action plan to build capacity of these health facilities over the next 2 years. But we are also working with other stakeholders within the areas of operation, because the action plan is quite comprehensive. And of course, as one actor, it will not be possible for us to cover all areas of gaps, and therefore looking at coordinating and collaborating with other stakeholders within the health sector in those areas. Such a deep dive analysis and ongoing monitoring would simply not be feasible in fragile conflict affected context under a 1-year time frame. Obviously, you need, the assessment itself took almost 6 months for the 185 facilities that have been done so far. So imagine if in 12 months you spend 6 months doing health facility assessments, there's very little time left to actually act on those priority action plan. But it is possible when you have a longer time frame to implement the program. Next slide, please. The next component is the CMOM surge. And as I mentioned earlier, ANI focuses on life-saving response, and central to this is, of course, CMOM, an approach that has been instrumental in, Concern has been instrumental in developing over the last 20 years, which many of you are familiar with. Many of you are using it in your programs as nutritionists. In most recent years, an enhancement of CMOM has been developed called CMOM Surge. For those of you who are not familiar, the aim of CMOM Surge approach is to help the health systems better anticipate, prepare for and deliver services for the treatment of acute malnutrition during periods of high demand. We all know that there is seasonality to malnutrition in many of these contexts, either driven by displacement or drought or other disasters, natural disasters. It is a sustainable response to persistent malnutrition. It's an 8-step process, and this table illustrates the various steps. The steps focus on understanding the health facility's capacity and environment, and identifying simple actions that can be triggered when malnutrition caseloads increase. The approach focuses on building capacity to respond to periodic increases in caseload to ensure that the quality of care is maintained. In the alert phase, as the process has several phases, you have alert, you have serious and emergency. In the alert phase, the focus is on internal reorganization. So maybe at the facility level, you're looking at, if there was a health worker that was due to go on annual leave, maybe suspend annual leave for health workers and just have that capacity there at the health facility level. While in the serious and emergency phases, support is from the district health teams or other partners for when the situation goes beyond the capacity of the health facility and local community. Next slide, please. Globally, CMOM Surge is implemented in 17 countries with support from 17 implementing partners. And as part of ANI, Concern is leading the global CMOM Surge task force that is looking at coordination of CMOM Surge activities and driving learning to maximize the quality and effectiveness of the approach. So this is coming as part of ANI. Within the ANI program countries, CMOM surge is being implemented at different scales because, as you know, it is an approach that has been around for a number of years. And some of these countries that Kansan has picked for ANI had already initiated the CMOM surge approach. And therefore, Ethiopia and Niger, CMOM surge was set up or is supported across 307 health facilities. While in Sudan, South Sudan, and DRC, we are looking at a smaller scale of implementation or adapted pilots, as is the case for South Sudan. Surge is implemented at scale in Ethiopia and Niger, as I just mentioned. Since the beginning of the program, Ethiopia has been able to set up 91 surge in 91 health facilities, and the setup has been in the Somali region. And since the setup, we have had the alert threshold breached in 2 health facilities in Somali region. Surge action plans were activated, and the actions included the redeployment of staff trained in CMOM from another unit in the health center, and increased community awareness campaigns. So we've seen how that works in Ethiopia and in other countries. A recent evaluation has also illustrated that when setting up CMOM surge in health post, the approach needs to be simplified, considering the capacity of health extension workers, and that there's only generally one health extension worker per health post. So there has to be an adaptation. And the adaptation, again, is only possible when you have a longer time frame, as is the case in the ANI program. South Sudan is where the model is being adapted, as I had mentioned earlier, and is being piloted in one of the health facilities in Unity State. Here, the outpatient therapeutic services are separate from the main health facility. And over the last 12 months, a surge action plan was elaborated for both the health facility and the OTP. And the action plan focuses on improving communication and coordination between the 2 units. That was seen as being very important to ensure smooth delivery of nutrition services. In September, we saw the surge action plan come into use when there was a surge in caseloads due to the displacement of the population following the flooding that is currently happening in Unity State of South Sudan. Caseloads of diarrhea and malaria were particularly high, with the emergency threshold therefore being breached, and human resources and supply support was provided from the OTP as well as the district health team. So this demonstrated a perfect example of how the surge action plan comes into play, and the coordination and the improved coordination and communication between the OTP and the health facility. Next slide, please. The other component is the early warning, early action component, and this builds on Kansan's experiences in Somalia, Chad, Niger, and Ethiopia. The purpose of the early warning, early action is to delay or prevent negative coping strategies leading to increased malnutrition. In slow onset emergencies, ANI provides a safety net type response to support basic needs. We've provided small cash amounts of cash or vouchers or in-kind assistance to enable or to prevent people from resorting to negative coping strategies. Scale up is sometimes required if the emergency extends, and we have been able to provide this early response because within the program, there is a pooled fund or a crisis modifier to facilitate these responses. The beneficiaries are households who are most vulnerable to food and nutrition crisis. They are pre-identified through a participatory risk analysis combined with structural vulnerabilities that make the situation more precarious. It is through this pre-identification that we are able to really respond early. Otherwise, it would not make much of a difference if that pre-identification is not done beforehand. Where there's a national social protection system in place, as is the case for Ethiopia, then we follow the same targeting criteria as of the national social protection systems. Should the forecasted emergency manifest, the targeted group may be enlarged to include additional households falling into the same vulnerability criteria. So scale is possible. In other countries, the identification of the second cohort of these of vulnerable households is also normally pre-identified. So that makes the scale up also easy if that structure is there. Otherwise, it would follow the same process as you would in any other emergency in terms of identifying beneficiaries. Next slide, please. To date, we've had 6 responses carried out. We have 4 ongoing and 2 planned. The budget for the crisis modifier is about 35 million. Is about 4.6 out of the 35 million, and can be used, as I said, for both sudden onset emergencies as well as early action. The activation of the pooled fund for early action is based on an early warning system that's developed at the local level. And the information is sourced from existing early warning systems, but also complemented with other information from the communities and other actors on the ground. The final component is around behavior change. As I said, part of the framework for building resilience for this program is behavior change communication. And an interesting model has been, or an interesting approach is being applied, and this is the father to father, mother to mother support group. And these groups have demonstrated to be effective vehicles for change. And through the program, Concern is working with change agents to promote behavior change, as well as linking the same groups to government systems to promote sustainability. Part of what happens within this group is that information is shared on feeding practices, on basic hygiene practices, and other aspects that contribute to malnutrition through the groups. The groups provide act as support mechanisms for each other. Demonstrations are done through the groups, and there's that follow-up and support system that is available to mothers and fathers in terms of behaviors and beliefs that are related to health and nutrition. The focus for these groups is not only on nutritional messaging, but also looks at uptake of health services or other health-seeking behavior, hygiene and sanitation practices, but also gender practices or norms that often contribute to the drivers of poor health and malnutrition. These systems are being developed and worked on at community level, whether it is the mother-to-mother support group or it is, the system strengthening that is being done. These are all being done at the local level, which is the most practical approach in the context of fragile and conflict-affected countries. It provides a framework through which nascent governments, as in the case of, let's say, South Sudan, can build on. It provides a platform that, you know, nascent governments can build on at community level. But the most important thing, next slide, please. But the most interesting thing about this program is the fact that, one, it is an ambitious program, but the fact that it is a program that is working on a long-term approach in context that would normally be considered as humanitarian emergency context. The planning, pacing, and scaling of what we can achieve with this program could not be done under a one-year program. ANI is about building resilience, and meaningful resilience cannot be built within a short time frame. I mean, Kate, during her opening remarks, talked of quality funding as one of the key enabling priorities of the grand bargain. And I think the PPP program has demonstrated what that quality funding can be. As our experience so far within the ANI is showing us, there are many benefits to having multi-annual flexible funding, as it allows us to work on a multi-annual programming and planning process. Aside from better planning, flexible funding, it also supports nexus programming within the conflict and fragile and conflict affected countries. The inbuilt flexibility in ANI budgets in each country enables adaptation and allows concern to respond to emergencies as they arise. The timeframe allows for meaningful engagement and capacity development of local actors, such as Ministry of Health in these countries, partners at the local level, but also communities over time. It allows for innovative approaches that integrate prevention and response, as well as adaptation from learning. Under the PPP, there's flexibility, as I said, built into individual country budgets, which is positive. It is a 3-year MOU signed between Concern and ECHO. However, to take this partnership one step further and have one flexible budget to cover the entire program could have been very powerful, rather than, you know, separate country budgets which are still linked to the global result framework. While ANI is a 3-year program supported by multi-annual funding under the PPP and has 5 countries working to one global result framework, it is still linked to the HIP system, the annual HIP system, which means that the final 3-year amount and beneficiary figures are subject to annual confirmation through the HIP allocation process. The fact that this multi-annual grant is being managed year on via HIP, it risks undermining the long-term goals of the PPP. It's therefore important in terms of ECHO fulfilling its commitment to enhanced quality funding, that future iterations of this particular funding modality in terms of multi-annuality and flexibility need to be looked into and find a modality that is not dependent on the annual allocation and get even closer to the true spirits of commitments under the grand bargain. I'll end my presentation here. I think I've taken more than the 15 minutes. My apologies for that.